Hi, everyone. Welcome to the Midlife Wellness NP podcast. My name is Kim Hefner. I'm a board-certified family nurse practitioner. I specialize in the care of the midlife and menopausal woman, and I'm the host of this podcast. So welcome. My next guest is a multi-award-winning physician that is dual board certified in both OB-GYN and Integrative Medicine. She is the founder and director of the Integrative Medical Group of Irvine, a practice that combines comprehensive healthcare for women by combining the best evidence-based therapies in naturopathic, holistic, and traditional medicine. She is a prolific writer and lecturer who speaks globally on women's health issues, and she is regularly published in peer-reviewed journals, which is pretty awesome. She is the best-selling author of the series PCOS SOS and her latest book, Menopause, 50 Things You Need to Know. I am thrilled to welcome Dr. Felice Gersh to the podcast. Dr. Felice Gersh, welcome to the Midlife Wellness NP podcast. It is my honor to have you.
Well, it's my pleasure to join you, and I'm so happy to be part of this movement, with the women's health movement to really educate and empower women.
Yeah, and you do just that. I was just saying how you have this amazing gift. You have all of these accolades and accomplishments and great books, but you have the amazing gift of teaching and taking these complex topics and making them easy to understand for everyone.
Well, it's so important for women to really understand what's happening to them at every stage of life, because the reality is that I think the real change is going to come from what I call the bottom up, from the population of women rather than from the conventional medical system down. We have to have like an uprising of demand for proper health care for women.
You are so right. I can't agree more. Well, the first thing I'm going to start with is a statement that I am sure you have heard, just like I have many times. Menopause is a natural transition. Just let it be. What is your response to that?
Well, we have a natural history of all kinds of things happening on planet Earth. And we don't say, well, it's natural, so who cares? Like hurricanes, tornadoes, earthquakes, we want to be prepared and we definitely respond. And if we had the power, we would want to prevent. So the fact that something is natural and inevitable doesn't make it beneficial. So in fact, we fight almost everything that's natural in medicine, and everything we do in medicine is unnatural. Natural is you just let disease take hold and whatever happens, happens. If you go blind from cataracts, that's life. If your joints are killing you and you can't get out of a chair, that's life. I mean, you can go through every bad thing that happens with aging and say, well, it's natural, it's part of life. And that is not the right attitude that we take in our really advanced scientific approach to optimizing health, which is to take things that may be so-called natural, but to optimize everything so that you have a higher quality of life. So, we call it healthy longevity, not just to play what I call medical whack-a-mole. So menopause is universal, it's natural, but the consequences are treated as if they should be addressed. So if you fracture bones, of course, you get put on various drugs and to try to lower the risk of further fractures. If your joints are bad, then they replace them. If you have high blood pressure, you can get put on multiple drugs and on and on. If you have, like I said, cataracts, they don't just say, oh, now you're blind. They say, let's replace them with new lenses. We do everything unnatural to optimize health as problems arise. My goal is to prevent those problems in the first place by acknowledging the naturalness of menopause and the enormous metabolic, which is about energy, everything about energy, the enormous consequences of menopause in the female body, and take proactive steps so that we don't have to do all this other unnatural stuff to deal with the consequences.
Right. That is so true. What a great explanation. Well, how do you feel that generations of women have been misled about menopause and hormone therapy?
Well, the thing that's interesting is that they did a survey, and it's not surprising that the vast majority, something like 80% of all the healthcare providers currently in active practice, whether they are like in terms of prescribers, so they could be nurse practitioners or PAs, MDs, DOs, 80% of them were not in practice when that monumental, in a negative way, hormone study called the Women's Health Initiative came out with like a lot of fanfare of negativity over 20 years ago. So we do have the vast majority of people in the world who are taking care of women who are transitioning into menopause, never having been exposed to the attitudes that existed towards hormones that predated that unfortunate study. So it seems like negativity has always been around, but in reality, I'm in that 20% that was in practice prior to and during this whole like emotional and every kind of explosion that happened with the Women's Health Initiative. And prior to the Women's Health Initiative, the attitude towards hormones was totally different. It was really hormones, and by hormones, I mean the hormones from the ovary, progesterone and estradiol, the estrogen made by the ovaries, they were viewed as what I view them as now, life hormones for sustaining health, like anti-aging, that they were not necessarily the fountain of youth, but certainly instrumental to healthy aging. And women were encouraged to be on hormones up until the Women's Health Initiative, which turned everything on its head. And so we really have to just acknowledge the unfortunate legacy of that study, which just, it's like in a grade B movie where you keep thinking the monster is dead and then it's back again. It's like, what? Did they already kill that monster? You know, you've seen that movie. It's like, he's back, you know, like, how is that happening? You know, like this is like a monster. I mean, I know that sounds really strong, but I really think of that study as a monster. And the number of women whose health trajectory has been modified in negative ways because of this negativity about hormones has really been like enormous, enormous. So we have to bury that monster. We have to get rid of it and move forward. And that seems so much more challenging than it should be. So what I try to do is explain what we do know, because unfortunately, after that study came out, it kind of shut down all research in terms of clinical studies, not scientific research, but clinical study. That means like using human females in a study. It really shut down most of the studies. And the couple of studies that came out afterwards, like the KEEP study, the ELITE study, they were so heavily influenced, and they even admitted it, by the Women's Health Initiative, that they like embraced this unfortunate mantra of the lowest possible dose. That became the the signature expression of the Women's Health Initiative. If you must use hormones, use the lowest possible dose. For what purpose? To suppress certain symptoms like night sweats and hot flashes, which it turns out, for better or for worse, it is what it is, the amount of estrogen in the form of any type of estrogen that is needed to suppress those symptoms, night sweats, hot flashes, is almost like a whiff. It's like a tiny amount can suppress those symptoms. But to optimize the function of all the different organ systems is a different amount, a much higher amount. So it would be like the bare minimum for survival is not necessarily the amount for thriving. So that is really important, the takeaway. So because those studies embrace this unfortunate, philosophy of use the lowest possible dose, that's what they used. So they actually measured, for example, in the KEEP study, the level of estradiol that was achieved by the hormone dose they used, and it actually was in the menopausal range. It never crossed the threshold into what would be viewed as a therapeutic dose. So of course, the outcome wasn't optimal, but even then in that study, it did show quality of life benefits. So women felt better. And that matters too, but they didn't show vascular benefit because they were using such a tiny amount. It would be like you did a study on exercise and you said, I don't know if exercise is good or is bad, but rumor has it that a little bit is the best. I mean, we just want to go with a little bit of exercise. So we'll have all of our study subjects exercise for 10 minutes a week. Okay, that's it, 10 minutes a week. And then you find, well, even 10 minutes a week, they feel better, but it didn't really show benefits for the cardiovascular system or the joints or the muscles. So I don't know, maybe it's not really that good, but it's like a little good, but not that good, So like, that's absurd. When you put it that way, of course, a tiny bit of exercise is still better than no exercise, but is it optimal? Of course it isn't. So like anything in life, you want an optimal dose, not just a bare minimum, slightly beneficial dose. And we cannot get out of that mentality. So the studies used the wrong types of hormones, even the subsequent studies. They still used the wrong dosage, the wrong types. They just were performed and designed by cardiologists who really didn't understand hormones. And so that's the state of the art as far as clinical studies, like people studies. But we have so much science. We know what these vital life hormones do in the body. We know what happens when you don't have them. And so it is where we are. We have to make decisions about clinical usage in the here and now. We can't say, okay, ladies, let's wait for the studies to come out. There are no studies in progress. There is nobody interested in creating these studies. There is no one funding anything, but we have lots of science. And so it just is. Back in the day meaning before Big Pharma came on the scene, where did they make decisions? How did they come up with recommendations? It wasn't based on large placebo-controlled double-blinded studies. That's an invention of Big Pharma. We did it through something else. It's called observation. It's called use experience. It's called other science, So we have to get back to other levels of evidence. In fact, they do rate evidence based on like, well, what kind of evidence? And they actually have a grade. This is a grade A, this is a grade C, this is a grade D. So, but they're all forms of evidence. So my thing is, we cannot wait for the clinical studies. They're not coming. It's like you're walking down a path 2,000 years ago in the forest. And there is no Google Maps. There is nothing, you are walking down a path, you know where you want to go, but it's just a little path. And then you get to a fork in the path. You can go right or left. And there's like no one telling you which is the right way. So you have options. You could sit down and just wait and hope somebody comes along to rescue you. I'm telling you, nobody's coming. Okay. Or you look at, I don't know, you look at the sun, you look at the stars, you look at the, which, landscape looks better. You use the evidence you have and you make the best decision you can, because doing nothing is a decision. If you just sit there and do nothing and you don't go forward, that is a decision, but not a good one, because you're never, obviously, if you do nothing, you'll never get to where you want to go. So you just have to make the best decision. That's where we are. And it's a much easier decision because we really do have a lot of science about what these hormones do in the body. And like I said, what happens when you lose them. So screaming this out, okay? Women, you need to replace the hormones that you are insufficient and deficient in. And like another easy analogy, if you have low thyroid, everyone knows thyroid hormone is really important. It does so many things throughout the body. If you are low, even a little bit low, what we call subclinical hypothyroidism, it's recommended that you be treated. Okay, that you want to get your thyroid to an optimal amount. In terms of fertility and pregnancy now, this is like totally a new way of looking at thyroid hormone, that you need to really optimize the levels in the body when you're trying to conceive or during pregnancy. Well, to me, you should always want to be optimized for everything. And, like not just when you're trying to conceive, but all the time. But that's thyroid. So why should we say thyroid matters, but estradiol doesn't? Progesterone doesn't. They're all hormones, and they all have a connection between one and the other. They all have their receptors. They all do very critically important things. We just have to think of estrogen and the form made by the ovary, estradiol, and progesterone as what they are. They're hormones. Hormones are the information deliverers. They are like, if you're trying to make a recipe and you want to make a dish, they are the recipe. And then you have to have the ingredients. The ingredients would be the micronutrients, the macronutrients, and so on. But you need that instructions. That's what the hormones give you, the instructions. So why would we treat a deficiency state or insufficiency state of estradiol and progesterone differently than any other hormone in the body, just because it's naturally going to happen that you're in a deficient state doesn't mean it's good. We have to get rid of that. Just because it's natural, it's good. Okay, we do not like that. Birth defects could be natural, but they're not good. If you have a cleft lip, we don't say, well, it's natural, you have a cleft lip, we won't repair it. That's what modern science excels at, is trying to fix natural problems, So it's so simple. Talk about simple thinking. If you are insufficient or deficient in a hormone, either fix the situation so that your body makes it appropriately, which sometimes we can do. Like in a reproductive age woman, we can do things to help her ovaries to work better. We can also give the right nutrients and help the thyroid gland to work better. But when you go through menopause, there is nothing we can do at this point. That may change, with stem cells or, ovarian transplants. But right now, there is nothing we can do to bring back the life and the function of those ovaries to continue making estradiol and progesterone. So we cannot fix the underlying cause of the deficiency. That isn't going to happen. So the only solution is give the hormones you're deficient in. It's so simple. You don't have it, you give it. If someone's starving, the solution is to give them food. I mean, this is like nonsense that we talk about these hormones differently than any other hormones. They are hormones, but they're not just hormones. They're like critically important hormones, pretty much more than most hormones. The only hormone in the body you can't live in a deficient state for 24 hours is cortisol. I mean, if you don't have any cortisol, you'll be dead in one day. But that doesn't make that the fact that you won't be dead in a day if you don't have your ovarian production of estradiol and progesterone does not mean that it's okay to live in a body that is severely deficient in those hormones. And so we just need to recalibrate our thinking.
I'm surprised how polarized it still is. Like you have OB-GYNs and them talking about, those old studies, but even the recent review of the studies still saying there is still some risk of breast cancer. You still only want to give it for symptoms. You only want to give it at the lowest effective dose. But then you've got the other side talking about the amazing benefits on prevention of disease and how it's replacing our hormones. And it's amazing. I can see how women are confused and still, well, I want to take it, but is it going to give me breast cancer? I mean, it's so sad that we're still at that point.
It's insane. It's sad and insane because, and the individuals who were responsible for managing that study will not change their tune to any significant degree. They've slightly mellowed, but not anything rational, because they're still, exactly as you said, continuing that whole thought process of, well, it's really not that bad, and maybe even have some benefits if you are early in menopause, like if you're only out 1, 2, 3, maximum 10 years. Or if you're under 60, maybe it's not so bad. Okay.
Yeah.
And they always use like they'll say, the risks are not that great. So you want to compare the risk to the benefits, and maybe in that age group, the benefits may outweigh the risk, but you're always putting that caveat of risk. So
Right.
every woman is being told, well, yeah, there is really risk here. So you have to weigh the pros and the cons, because there are a lot of cons, which is absurd. No one says that when people are prescribed thyroid. They never say, well, let's weigh the pros and cons of trying to make you euthyroid, having a normal thyroid level. No one says that. Nobody even thinks that. Like, if you are a type 1 diabetic and you don't make insulin, no one says, hey, let's weigh the pros and cons of having insulin that
Yeah.
you don't make,
Right.
because
Right.
like,
Right.
oh my goodness, it's like
Right.
so crazy. The risks and the benefits they keep putting, just like you said, well,
Yeah.
there are these risks, and the risks are, well, you might have dementia, you might have a stroke or a blood clot, or, oh my gosh, worst case, breast cancer. Like, bioidentical, human identical hormones actually have a mechanism to give you all these terrible things for, no obvious reason. At whatever age you start menopause, it sort of goes into play. And the range of ages when a woman goes into menopause, which is an artificial definition anyway, which I'd like to touch on, but
Mhm.
the age that a woman goes into, by definition, normal is 45 to 55. That's 10-year span right there. So
Right.
if a woman goes into menopause at 45 or 46, at that point, hormones become dangerous. But if she doesn't go into menopause for 10 more years, they become dangerous a decade later. Like, what is the thinking process here? This is like a really key point. Every cell in your body, except for a few, like that may be in your heart and in your brain, are different ages from the age of your birth. Okay. So cells in your body die, and then they get replaced from your stem cell pool. And by the way, estradiol helps to maintain the stem cells. But the bottom line is, that's why we all love stem cells. If you run out of functioning stem cells, then as cells die, you can't replace them. So your organ will decrease in its ability to function, and then you will ultimately die. That's why the function and numbers of stem cells dictate maximum lifespan for every living creature, right? That's why we can't live, no matter how much we do all good health things or go on hormones, we cannot live to be 200 at this point, because our stem cells won't last that long. We can't like keep rejuvenating, replacing cells. But
Yeah.
the cells in our body, when they are made, like for example, bone has what we call turnover. Bone cells are living cells, and they die and then they get replaced. And so the average time that a bone cell will live is 7 years. That's like the typical lifespan of a bone cell. Different cells in the body have different amounts of time that they can survive. And the thing is that when a new bone cell is born, it doesn't say, the body I'm in is 65, so I'm going to behave differently. No, it's genetically programmed by its genes to do whatever it was genetically programmed, the same as if it were born 30 years earlier in your body. So once you recognize that most of the cells in your body are all different ages, and they don't know how old you are, they don't even think about how old you are. They don't have that ability. They just do what they're genetically programmed to do. If you give them what they need, which is the micronutrients, the macronutrients, all the minerals, the vitamins, the proteins, the fats, and all that kind of thing. And you
Mhm.
give them what they need, and then you give them the instructions so that they know what to do with it. Once again, the hormones.
Yeah.
So then your cells can behave at any age as if they were like 25 years earlier in you, okay, even though they're just new cells. So we have to try to replicate the most optimal environment for every new cell that's born. Now, can we do that? The answer is no, because no matter how hard we try, we cannot create the exact same environment hormonally as a 21-year-old would have when you're 65. But we can do a heck of a lot better and slow the aging process. That is the goal, not stopping aging. We don't have that power, but we can slow it to create what I call super agers. Super agers are, I'm going to focus on women who at 95 can do virtually the same things they could do. I'm not saying identically, but like they could do at 35. Like, for example, they could learn a new game, like they've never played bridge. Well, they can learn how to do bridge. They can learn chess. They can learn dance steps. They can travel around the world. They don't need wheelchairs in airports or, and, they can follow complex plots in books and movies. They can hike long distances. They can do swimming. They can even do diving. I remember seeing a previous woman Olympic champion in diving, and in her late 90s, she was still doing all kinds of interesting dives. It's like, yes, there are people that I've seen women in their 90s doing yoga poses, on one hand. I mean, it's like, wow, So the goal is to, do everything to be a super ager, but you can't likely be a super ager if you don't have hormones. Now, yes, there's always that one person who wins, and this is true, the $1 billion lottery, right? They've actually had lotteries that went up to, but how many out of the population won that lottery? So if you think that you're the outlier that will be the super ager, even though you don't do much of anything to try to be a super ager, that is medically unlikely, we'll say improbable. But if you get hormones and then you do all the lifestyle stuff to support the cellular functioning, and of course, that includes eating the right foods, having fitness, proper sleep, work on stress, environmental poisons, and all that sort of thing. If you do it all, your probability of being a super ager astronomically increases. Your cost to society for healthcare will plummet. You won't have all kinds of pharmaceuticals on board, which are unbelievable, the number of drugs that seniors are taking. I mean, often the drugs are for more drug. You have the drugs to treat the side effects of the other drugs. And often different drugs are counteracting each other because they're all prescribed by different doctors who are trying to micromanage different organ systems. I'm trying to macromanage by giving the body all the basic things and letting it micromanage itself, not trying to change this enzyme pathway and that peptide production. I'm just trying to say, give the body what it needs, let it do its own thing, just like a healthy 21-year-old. You don't have to micromanage the healthy body of a 21-year-old. That's what I want for a 60-year-old, a 70-year-old, a 95-year-old. And it's not impossible. This isn't like a fantastical dream, but it's never going to happen in our world, which is even more challenging now than in the past because of all the chemical toxicants, the endocrine disruptors that we're up against, the food, the crazy food and the air pollution and water pollution and all that. So we have a few strikes against us just living in this modern world, and we have to make sure that we, make all the right choices as best we can and get air purifiers and water purifiers and try as much as possible, even though it's so much more expensive to buy whole foods, organic foods. There's even an article I just saw this morning that organic food, when it's raised organically, it actually changes how the genes are expressed in the plant, So every living creature, every living organism, including plants, are affected by poison in ways that change how its genes are basically expressing themselves. So these are really critical things. And once we just treat estradiol and progesterone as just really essential hormones that decline naturally but not beneficially, and then we just like bury that monster of the Women's Health Initiative, then women have a much better fighting chance of achieving healthy longevity. Women, compared to men, statistically live a few years longer. but they tend to live with more chronic disease. Women have at least 2.5 times the incidence of Alzheimer's disease. Women by the age of 65 are more prone to strokes and ruptured aneurysms than men, to die from their first heart attack more than men. By age 65, without hormones, 75% of women will have hypertension, high blood pressure by age 65. That's huge, 75%. And they will mostly have high cholesterol because estradiol regulates every aspect of cholesterol, how it recycles, how it's produced, whether it's oxidized, becomes rancid, which is the ticket to getting plaque in your arteries, atherosclerosis. So women start having a lot of cardiovascular disease. Women have much more incidence of what's called heart failure with preserved ejection fraction. In other words, the heart can pump okay, but it doesn't relax properly. The relaxing is the phase when the heart is refilling with blood. And it's basically an energy deficient, stiffer heart, way more prominent in women because women's hearts need more energy than men's. And it's all related to the ability to have a successful pregnancy, because in pregnancy, the heart volume of the blood volume increases by at least 50%. So you have to have a more energetic heart for successful pregnancies. And so when you don't have enough estradiol, your heart actually suffers more from this energy deficiency state in women, because it's not just, it turns out it's so amazing. The heart needs so much energy, and estradiol has receptors directly on the muscle cells of the heart, the vascular system that supplies the nutrients and oxygen. It also is on the energy producers, the mitochondria. But there are also receptors in the heart and on the mitochondria for what are the metabolic byproducts of estradiol. So it goes through the liver and is metabolically transformed into other hormones, like one is called 2-methoxyestradiol. It's a metabolic product of liver transformation, like sort of what they call detoxification. It's a transformation in the liver to another form of estrogen. And that particular metabolic byproduct has its actual own receptors. That's how important, even the byproducts. And then there are what are called estrogen-related receptors. So what binds to the receptor, like a hormone and a receptor, like it goes in, fits like a lock and a key, but the lock is not static like a real lock. It can be like open or closed. So it's more like amorphous. But when you have these other, what they call ligands, what binds to the receptor, it's not estradiol, it's something else. We don't even know what it is, but it won't bind and create energy in the heart unless you have estradiol in the neighborhood. So they call them estrogen-related receptors. So they're on multiple levels. We need estradiol, and real estradiol, not some fake pretend estrogen, because that's where the Women's Health Initiative failed. Every woman, because they didn't use human bioidentical estradiol, the estrogen made by the ovaries. They used what was used decades and decades and decades ago, before smart people knew how to create essentially identical estradiol. Just like years and years ago, they used insulin from a rabbit because they did not know how to create human identical insulin. And that didn't work out that well. But now we have insulin that is identical to what the pancreas makes. Years and years and years ago, they didn't know how to make identical estradiol. So they did what they could. They used a pregnant horse, and then they took the urine that came out of the pregnant horse, and they basically powderized it and made it into a tablet. And then they fed it to females. And it turned out that even that crazy, never in a human type of combination of estrogens, and the horse was getting rid of it. That's why they call it conjugated, because it went through the liver and was modified to make it turn water soluble instead of fat soluble, so it could go out the urine. So they called it conjugated equine for horse, estrogen. So it wasn't one estrogen, it was a whole conglomeration of different estrogens that would be in a pregnant horse after it goes through the liver, never to be seen in a human. They're called equiline estrogens. They're never in a human female, along with a bunch of other junk that would just come out with it, okay, like weird stuff. So then they created these tablets, and that's what they gave to women in the study, the Women's Health Initiative, for the estrogen. And shockingly, even that, which isn't a human product at all, actually had some benefits. I mean, that's like the weirdest thing ever. But what happened was, because of what it is, when taken orally, it increased the risk of spontaneous inappropriate blood clotting by 4-fold. And if you give it to an older, unhealthy woman, which is what they did, because the average age in that study was 63, it went all the way up at the beginning to 79. And they said healthy women. I can tell you they did not find like thousands of healthy women in their 60s and 70s. They had every metabolic problem, hypertension, diabetes, heart disease, everything. They were not like pristine, healthy women who were in their late 60s and 70s. They were just average American women of all sorts. Many were obese, and they gave them this substance that increased their risk of blood clotting 400%. So if you do that, you're going to increase risk of things like strokes and blood clots. And if you get blood clots in the blood vessels feeding the brain, then you could get increase in dementia called vascular dementia. So like, duh, that's what they found. So the solution or the conclusion should be, don't give that. But that wasn't the conclusion. The conclusion was estrogen is evil. So, and so don't give it. It's like dangerous. They also found that in that study, that unfortunate study, they did not use bioidentical progesterone either. They used a different chemical called medroxyprogesterone acetate. Now, it has the word progesterone in it, but it is not progesterone. It's a different molecule, and it has a different effect. And unfortunately, it turned out that that molecule increases, but not a lot, but it does increase breast cancer risk. So it wasn't even the conjugated equine estrogen that increased breast cancer risk, just a little bit. It was this other chemical that was included. And when they took out that other chemical, what they call a progestin, that's a made up word for a mimic, a pretend, but not real mimic of progesterone, but it's not, it's like the evil twin. Okay. It's not the same. It's like the evil twin. And when you took that out, because they didn't give that to women who had had a hysterectomy, they don't even understand what progesterone does in the body, which should always be with it, with the estradiol, but they didn't know that. So they didn't give that chemical to women who didn't have a uterus in that group. And then they followed it out. Like you said, they keep reevaluating it like 20 years later and plus, and they found that those women had a lower incidence of breast cancer. So even that crazy stuff from the pregnant horse actually seems to lower breast cancer incidence, but you never hear about it. Like, where is that in the media? Like, nobody. They're just, so the conclusion should be very simply, don't use those things. Don't use those things. And so, but that wasn't the conclusion. It was like, this is my analogy for that. You do a study with strawberry flavored jelly beans. You find that it increases cavities and diabetes and obesity. So the conclusion is never eat an organic strawberry. I mean, it's like, excuse me, you didn't study organic strawberries. They didn't study bioidentical estradiol and progesterone, and yet they painted with this horrible black brush every kind of hormone like they're all the same. It would be like saying trans fat is bad. We did a study with trans fat, so never eat. By the way, this kind of happened. Remember when fat was demonized? And they say, don't eat avocados. I remember they said, don't eat walnuts, don't eat avocados. And I remember at the time, because they have fat. And it's like, well, but wait a minute, you're telling me that avocados are bad for your health and walnuts are bad for your health. Olives or, organic olives are bad for your health because they have the same, obviously, fats that you get from olive oil, they're in an olive. So it's like, that didn't make sense to me. But remember that, I don't know, you remember, you're too young, but this was real. This is real. They said, fat is bad. Don't eat fat. And it's like, what? You know, how
Right.
fat, they call them essential fatty acids. And these are essential life hormones. So
Right.
this is the same nutty stuff that's happened in medicine before. It's like, don't eat fat. It's like, what? Don't eat avocados and walnuts. So, like this is absurdity. So you
Yeah.
do a study and the conclusion applies to what you studied. You don't
Exactly.
then make these giant, broad, like recommendations that affect things you didn't even study. Okay. That is like insulting to every woman's intelligence, but
Right.
nobody presented it that way. It's
No.
horrible. And they still are doing it. Like they won't stop. The people who were involved in that study will not stop saying they say hormones should not be used for health benefits, for the heart, for the bones, for the brain.
Right.
Like, don't use it. They actually say, don't do it. It doesn't. And the US Health Task Force came out like last year, and their official recommendation was in black and white words on the page, do not prescribe these hormones. And they just use the word hormones, like what
Mhm.
hormones,
Mhm.
They do not prescribe hormones for prevention of any medical condition. Oh my gosh, when I read that, my heart was ultra broken again. It's like ever how many times can my heart be broken? I definitely need more estrogen. Okay,
Right.
it's like,
Right.
oh my goodness.
Yeah.
It's like that's the official position of the US Health Task Force is
Right.
not to prescribe hormones for any prevention purpose at all, only to use the smallest amount, the shortest time for the worst hot flashes. And they're still coming out with that same recommendation that if you go on hormones, once you hit this totally ridiculous, arbitrary, unsubstantiated, absurd age, they say, of 60, you're now officially too old, and it suddenly becomes too dangerous to
Yeah.
be on bioidentical hormones if you're more than 10 years or age 60, whichever comes first. So
Mhm.
if you were one of those people and you went into menopause at 45 and now you're 55, well, you're 10 years out, time to stop hormones. Like, what the heck is the basis for that? It's going back to that same insane women's health initiative where if you gave it to the Prem-Pro, the conjugated equine estrogens with the medroxyprogesterone acetate to elderly women who were unhealthy, obviously, it
Mhm.
increased their risk of blood clots and breast cancer, the blood clots by 400%, the breast cancer by like 23%, something in that
Mhm.
range.
Mhm.
So it's too late, you're too old, don't start them. And if you're on them, you should stop them. Now,
Yeah.
the Menopause Society, formerly known as the North Menopause Society, which I canceled my membership, which I was very strong supporter up until the Women's Health Initiative, and then I canceled my membership and
Mm.
will never join them again because they echoed all the same nonsense from the Women's Health Initiative. They were a force of negativity in the world of women's health. They backtracked a little bit in the last few years, and they came out with a statement back in 2017, which they echoed in their more recent
Mhm.
policy statement, which is you can use hormones for life if you're like under very close supervision. I don't have a problem with that. But they also kind of implied like, well, you got to look at the risks and the benefits because there are all
Mhm.
these risks, like, oh my gosh, like there's risk. And you have to think about why you'd be on them, what's your goal. And it can include quality of life because, they put that nebulous thing in there. So it gives me a official green light to prescribe them forever. But they
Mhm.
also say, don't start them over 60 or 10 years out. You're too old to start them. All still nonsense based on all kinds of crazy conclusions, broadly applied to the wrong, unrelated hormone products. And so they're never going to see a penny of my dues, I can tell you. I'm glad that they slightly softened their position, but
Mhm.
not where it should be. Not at all. They're not the leaders in like marching forward for women's health by saying, hey, come on, we got to prescribe this for health benefits. Nope, not there. So now, but this is where we are. And so I should not be an outlier. I should be mainstream because I'm the most mainstream doctor ever, in that everything I recommend is science evidence based. It's like I said, it's what is your evidence? Okay. It does not have to be a giant clinical study. It can be science. And I know every bit of science that's been published about these hormones, and it's all plus, in the plus positive zone, if you're going to like weigh anything. And what are the downsides? What are the risks of being on bioidentical hormones? Pretty close to nothing. The biggest risk is that you'll have irregular bleeding if you have a uterus, because you have a uterus and you give hormones, it can grow a uterine lining, and we can't always control when it sheds or when you bleed. So that could lead to having to do ultrasounds or a uterine biopsy, things like that. So you have to, evaluate abnormal bleeding, but that's not something people die from. You're not like you just have to deal with the fact that you have a uterus and you might grow the uterine lining and it may shed inappropriately, because we can't identically give hormones to what a 21-year-old woman had. Someday, I hope we will. And they're actually looking at ways to maintain ovarian function, but the only thing they have now that is in research is taking a piece of a young woman's ovary out and then storing it and then putting it back when she's older. Kind of like egg freezing, only it's ovary freezing. But you have to do damage to the ovary, and you have to do a surgical procedure to get that little piece of ovary out. But they're actually saying you could extend the lifespan of ovarian function by like another 20 years if you take a little piece of ovary out and you save it. But that's a lot to ask of people. I hope we can have a better way. Maybe we could do like cloning or some other kind of thing. But there are people that are working on this, and I applaud them tremendously. Good, because they're actually saying, hey, this is good. The longer you have ovarian function, the better off you are, but until we actually have that available, we'll just keep doing the best we can to replace the hormones. And when we replace them, we don't want that stupid mantra of the lowest possible dose. We want the more sane mantra of an optimal dose. Just like exercise, we want to do optimal amount. We want to eat an optimal amount of food. We want to get an optimal amount of sleep. We want to have an optimal amount of our hormones. It's like the simple thinking. It's like the most duh. We just want to be optimized.
The thing is, a couple things I want to set straight. Well, so if you're a provider like, me, or if there's any question that you are not exactly following the guidelines or the hormone therapy physician statement, doing it exactly how it's outlined, then you're off base. You're not, following medical guidelines. And so there's that one thing. And then also, people, you can't use it for disease prevention, even though all of the research shows it helps with cognitive function, dementia, heart disease, osteoporosis, genital urinary symptoms. So that's confusing because we know all the benefits, but yet we're not supposed to prescribe it to prevent disease, only treat symptoms, which, like hot flashes and night sweats, can increase your risk for disease, right?
Yeah. Right.
So I want to ask you your thoughts on that, but also when you talk about optimal dosing, I've had patients ask me what's optimal, dosing wise, if this amount treats my symptoms, but is it actually helping me prevent disease? So maybe you could talk about what that looks like. And then another thing I would love for you to address is, this was just said today, people that are prescribing progesterone in women that don't have a uterus are not following guidelines. That's inappropriate. So respond to that as well, because I have been taught or learned that micronized progesterone has benefits beyond just endometrial protection. So yeah, I gave you a lot.
Oh, those are great. Well, starting with that last little part, there is no enzyme. There is no neuropeptide. There is no neurotransmitter. There is no hormone that does one thing. That's just not how it works. Everything is multitasking in the body. There is no hormone like progesterone that would do one thing, just protect the uterine lining. That's absurd. There are receptors, just like with estrogen, receptors throughout all the body. Progesterone is very neuroprotective. It's great for the skin. It's great for the musculoskeletal system. It has effects everywhere. And it also affects the gene expression of cells, the receptor function. And it's not like just regulating periods. I mean, that is so insane to even think that that's all it does. Now, here's a good thing. When we prescribe, like people like me, doctors and others who are prescribers, when we prescribe for health benefits, when we give cyclic progesterone in women who do not have a uterus, that is not illegal. It's really important. There are many, many drugs and even medical devices that are used off-label. So it's not approved by the FDA for a specific purpose that you are utilizing it for. But it's really important for the public to know that we're not like, I'm not sneaking around doing something illegal. There's nothing illegal about prescribing hormones for health benefits. There's nothing illegal about prescribing progesterone to women without a uterus. These are off-label usages. And there are so many drugs and, like I said, devices that are used off-label. It's commonplace. So no one should be afraid of using something off-label. So that is totally acceptable. But it's always disturbing that it has to be used off-label. I mean, it shouldn't be. It should be on label. It should be that everyone is supporting this, that the FDA stops putting the warnings on bioidentical hormones that they put on birth control pills as if they're all the same. Once again, it would be like putting a warning on an avocado that would be the same as if you put a warning on trans fat. This is like crazy stuff. The same warning does not apply because the risk is non-existent. They're not the same risks. It's just so frustrating. It would be the same thing like ultra-processed food has a lot of bad effects. We know that, right? Ultra-processed food. But what the heck does that have to do with organic whole foods? Like nothing. They're different. So you wouldn't say, oh my gosh, you better not, based on studies on ultra-processed food, that you wouldn't make a conclusion food is bad for you. I mean, it's just all the same craziness. So it's an important thing for every provider who may be listening to know that you don't have to feel like you're sneaking around. It's totally legit and legal to use hormones off-label for what we're talking about. The fact that it's not like endorsed doesn't mean that you cannot do it. There are many drugs that are not endorsed for something that are used for something. But I want it to be mainstream. I want it to be the standard of care that everyone wholeheartedly embraces. And so that's part of my mission. That's why I keep writing articles to get published in mainstream journals. And I keep thinking people will read them, but not very many people do. It's like the doctors' brains are stuck in this like warped time warp thing, from that Women's Health Initiative. And because the people who were involved in that study will not stop publishing articles, and everything they write gets published in some of the best, so-called best journals, that they keep echoing that same refrain, referring to all hormones as if they're the same, and then still maintaining that same approach. So it's really problematic. In terms of progesterone, there's so many benefits to progesterone. And when you give it to mimic-ish, it's not identical, sort of mimic-ish, a menstrual cycle where you have like 2 weeks on, 2 weeks off. So you have 2 weeks of progesterone, then you don't. The 2 weeks it changes how genes express themselves, the receptor function, like progesterone downregulates the receptors for testosterone, for itself, for estrogen. Estrogen and estradiol, it upregulates progesterone, thyroid, testosterone, and its own receptors. It changes how genes are expressed. We need to know that we are not smart enough to micromanage gene expression and receptor function. We are not. So we have to just do what we can to mimic a natural hormone cycle and let the body, like I keep saying, micromanage itself. These hormones trigger the production of peptides like around the body. And I know there are a lot of people that are doing all this peptide stuff. And I'm not saying that there can't be uses for peptides. Right now, I think it's for the compounded, it's like premature to use them. That's my opinion, because most of the data is in rats and we don't even have any real dosing recommendations. We don't even know exactly what people are getting. Is it active? Is it pure? Is it whatever? But so I think there's a future, but the reality is that if you maintain optimal nutrition, fitness, and hormones, the body will produce its own peptides as needed. Like one of the peptides that is so in the news today is GLP-1, glucagon-like peptide 1. So guess what? That peptide doesn't even work properly if you don't have enough estradiol on board. And you can increase the production naturally by having enough estradiol on board, eating a lot of fiber foods like we call like resistant starch and exercising and you can, I mean, our bodies have mechanisms to make it itself. One of the things that happens when you don't have enough estradiol is that you have dysregulation of the fat produced called adipokines, fat produced hormones, including leptin, which regulates appetite. So you get dysregulated appetite, more binge eating in postmenopausal women, and adiponectin, which triggers burning of fat. So in menopause, women accumulate more visceral fat, belly fat, appetite dysregulation, trouble with glucose transport. They do not burn fat well, mitochondrial dysfunction. So there's like a host of things that come into play. And if you go on hormones and you stay on them properly, you can actually dramatically lower that otherwise almost inevitable weight gain that now all these women are on Wegovy and Mounjaro and so on. You can actually prevent that in large measure through being on hormones and then adopting the healthy lifestyle. And then you don't have to have all of that unwanted and very toxic inflammatory belly fat that you then have to take drugs, which are mimics of the real peptide. They're not even the real peptide, to try to control these different things. We have my goal is to activate our own innate mechanisms to keep us healthy and not have to take $1,000 a month drugs, so, but we can do this. We can do this, but we can't do it if we have no hormones. And so I wish it weren't off label, but there's no way, unless it becomes illegal, which cross our fingers, that would never happen. There's no way that I wouldn't continue to prescribe hormones for health benefits because I know the science, just like I was telling you about GLP-1. And, this is ridiculous. You never even hear that. And you never even hear that postmenopausal women on the GLP-1 agonist drugs, they'll do better if they have estradiol on board. It will work better. And then talking about how to naturally, where's the talk about how to naturally increase GLP-1s? This is like, why are we not having these conversations? It's all about the drug, the drug, the drug. Much of this is actually, of course, paid for by the drug manufacturers. I'm not saying there's no use for drugs. I'm not an alternative medicine doctor. I'm an integrative, which means I integrate the conventional with what I call my enlarged therapeutic toolbox. But I haven't like shunned all natural medicine, nor have I shunned all pharmaceutical medicine. I just try to be smart in terms of what is optimal for a patient to use. What's the most effective and safest modality and what's the most natural if we can. If somebody comes into my office and their blood pressure is astronomically high, I'm not going to say that just eating vegetables is the only thing to do, but I'm not going to say don't eat. I mean, I'm going to say eat vegetables and exercise and work on sleep and all that, but I am going to give them a blood pressure drug because I don't want them to have a stroke tomorrow,
Right.
But so I'm not anti-pharmaceutical, but
Mhm.
I mean, to not even have a discussion of how can we avoid hypertension? How can we avoid heart disease? How can we avoid obesity? And I don't hear enough of that, especially when it comes to women's health and women's hormones. So that's why I appreciate you so much for helping to get with me the word out that we can be proactive, and by going on hormones, adding in all the important lifestyle components, prevent all of these preventable diseases.
Mhm.
And then all the massive pharmaceuticals and procedures that are used in what I call medical whack-a-mole to try to treat each problem as it arises.
Right, right. A couple things. I know that's why it's always shocking to me when I hear people saying that menopause, when we talk about hormone therapy, we're over medicalizing menopause, because I'm
Oh,
like, okay, we're trying to give hormones and instead of antidepressants and all of these other things, right? It's like, that's crazy to me. But back
oh,
to the,
absolutely.
oh,
And you're right. This is where the conversation is going now. It makes me want to pull my hair out. They're saying menopause is real. The symptoms are real. And women in the workplace, I know this is what you're talking, they are
yeah,
becoming less productive during the years when they should be the most productive and rising stars and everything. But and so the what's their solution? It isn't hormones, it's
mhm.
accommodations. It's treating women as a protected class of, special needs people. It's like, I don't want to be a special needs person. I just want treatment. Okay. Like, this is crazy. So you're going to have workplace accommodations, like you'll
Right,
have sweat breaks.
right,
You'll have
right,
like you can have a wardrobe room where you can keep changing your wet clothes. I mean, I don't want accommodation. I want resolution of the problem. But you're
right.
100% right. It's crazy. It's like recognizing menopause is a problem with productivity, quality of life. And the solution is just give them more breaks and more clothing changes. It's like, oh,
Right, right.
or
Well,
give them a drug. You're like a drug that came on the
right.
market recently, neurokinin 3,
Yep.
blocker. And yes, that, like everything in the body, no neuropeptide does one thing, right? So it does other things in the liver and gallbladder. That's why it now has a warning of you could have liver problems.
Mhm.
It's like, and it does nothing else except suppress night sweats and hot flashes. And it doesn't do it 100%. It's not like 100% effective for 100% of women. No, it is not. It costs almost $700 a month, at least the last time I priced it. And it doesn't actually improve anything else. Now, I mean, yeah, menopausal hot flashes and night sweats are associated with other bad things because it's affecting your sleep and your cardiovascular
Mhm.
system. But why would we give, like, just like you were saying, why would we give a drug to treat one thing? Like, oh, after, like with the onset of menopause, even a woman who never had a history of mental illness doubles her risk of anxiety and depression. And if you had a prior history like PMS or postpartum depression, her risk goes up 400%. But the solution isn't like give the lady some hormones. No, it's give her antidepressants.
Mhm.
Or, you could do other stuff too, like,
Mhm.
shock treatments or whatever,
Right,
like,
right.
but it's not like root cause medicine, which is what, we in functional medicine and integrative want to do. Root cause, like, why is this problem happening? Can we address that? And
Right.
the answer is yes, but that's not
Yeah.
the way big pharma is addressing it.
Right, right. When you talked about micronized progesterone, I just want you to touch a little bit on the fear I think comes with using it, because back to when they used the estrogen alone, breast cancer reduced, right? So I think that's the thinking still with
Mhm.
micronized progesterone. Can you talk about a little bit about that? I heard you talking about, which was amazing, how estradiol and micronized progesterone actually protect against breast cancer. And then I had a question with the route of micronized progesterone, with
Okay.
the mood and sleep and all of that. If people use it orally versus vaginally, or does it work? Are you still getting those benefits? And then,
Yeah.
maybe touch a little bit on people that need birth control and that they don't want to use birth control pills, which I think would be great. Other options in that arena.
Well, first of all, it's really important that we do not mix up medroxyprogesterone acetate with real human bioidentical progesterone, whether given orally or transdermally or vaginally. It's not the same. Once again, it's like the evil twin. It's not the same, and so on. Well, what medroxyprogesterone acetate is essentially what we call an antagonist slash agonist for progesterone. That means that depending on the organ, it can act as a progesterone mimic or a progesterone blocker. And even when it acts as a mimic, it's different. It has a different half-life, and it binds to the receptors differently. Even when it's an agonist, like it mimics progesterone, it's not the same. But it turns out that in breast tissue, it appears to act as an antagonist. So it actually blocks the benefit of progesterone in the breast. So it's technically an endocrine disruptor. Okay, so an endocrine disruptor means that it interferes in any or many ways with the production, utilization, receptor function, distribution, elimination of a real human hormone. So medroxyprogesterone acetate is officially an endocrine disruptor for progesterone. So it would be like a plastic bottle being compared to bioidentical estradiol. The plastic bottle contains, it could be, BPA, bisphenol A, or it could be phthalates, depending on if it's hard plastic or soft plastic, but they're all endocrine disruptors for estrogen. So they're also called xenoestrogens. They're fake ones, and they have a negative effect, very negative effect. So we would never compare, if we were thinking about it, taking a plastic bottle, grinding it up into powder, putting it in a capsule, and saying when you swallow that, you get the same effect as if you had your ovaries producing the proper estrogen. But yet we're doing that with the progesterone versus MPA, medroxyprogesterone acetate. So we just have to let that go. That's another part of that stupid, unfortunate legacy of the Women's Health Initiative, comparing, poison to bioidentical hormones. We have to think of the endocrine disruptors mostly as variants of poisons, okay? Like grinding up plastic. So we just have to stop thinking about those things. They're really not the same at all. And just, now tell me what the other question was. I don't want to forget, because you asked some really good ones.
Oh, just how micronized progesterone and estradiol can actually protect against breast cancer,
Oh,
rather
sure.
than using them both, which is, I think, the fear, especially those without a uterus, increasing the risk of breast cancer.
All right. Well, just have to remember that the increased risk of breast cancer, which was interestingly small, but it was from this progesterone mimic, so it was a fake progesterone that had an anti-progesterone effect in the breast tissue. Progesterone is very anti-inflammatory. It actually lowers inflammation. And when they actually have studies, this is so interesting. In a normal menstrual cycle, when a female has her period, you can think of it as a purge of the uterine lining, which now becomes like filled with dead necrotic cells from the uterine lining, and it has to be purged. So it's like a purging. Well, they actually have done breast biopsies at the time of the period, and they found that there was programmed cell suicide that they call apoptosis in the breast. So when you have this cycling, you can think of it as a purging, not just of crappy old cells in the uterine lining, but of crappy old cells, what we call senescent cells. Sometimes they call them zombie cells. They're the kinds of cells that can turn into cancer. And you need the proper mechanisms in play for the body's systems to actually cause those programs to actually be triggered. So crappy cells literally kill themselves. And that's programmed cell suicide. That's the body's way of preventing cancer by actually causing the breast cells and other cells elsewhere in the body that are these yucky cells with misfolded proteins, they're old cells, senescent cells, the zombie cells, to actually kill themselves off. And the menstrual cycle actually does trigger the yucky cells, and you need to have significant amounts of estradiol. It's important to know that dose does matter. That mantra of the lowest possible dose is not inducing the proper response throughout the body in terms of these critical cellular functions. And you have to think of the menstrual cycle as well. When a woman has the lowest amount of estrogen produced by the ovary during the menstrual cycle, it's when she's bleeding. That is the time when her estrogen is the lowest because it's the most pro-inflammatory. So that's when you're like having inflammation in the uterus. So to create some cramping to help push out the contents of the uterus. So we don't want to have the most pro-inflammatory estrogen levels, which are the low levels. Sorry.
You okay? You need a drink?
Okay.
Okay. Yeah. I was like,
I hope you edit. You can edit, right?
Oh, yeah. No worries. Yeah. No, that's good because that I really wanted to get that home with people to understand that. Yeah. So estrogen, it would be great if you could talk about that right dose because I think that is so confusing for people. I don't have symptoms now, so I must be on the right dose. But then that might not be enough for the other benefits you're talking about.
Well, in the conventional world, they never test levels.
No.
Those levels are irrelevant. It's all about those few symptoms. If you get rid of those symptoms, that's mission accomplished.
Yes.
So like I said, it's sort of a blessing and a curse that the amount that is needed to suppress those symptoms is way below the threshold to optimize health. So what is the right way to do it? Probably not what I'm doing or what most people are doing. It's complex and we have no published data. It's to really try to mimic a real menstrual cycle. The way that the estrogen is produced, it starts low, it rises, you have a big spike that leads to ovulation. You get the spike of the LH after the estradiol spike. And then you have a dip and then it comes up, it plateaus. And then if you're not pregnant, the estradiol drops. The progesterone will start being produced after ovulation. You get like a nice little mound. And then if you're not pregnant, it comes down. Because we now know that genes, including tumor suppressor genes, are turned on when you have the peak of estradiol with the spike, the peak of progesterone with its high mound peak. But we have no data yet on that. But the reality is that that's probably optimal. Anything that you do to mimic what really happens in the body is probably really the best way to go. So what's a second substitute that you can do? Secondary, but maybe not as good, but it's what we can do. And we do have data. That would be to give an estradiol dose that gets you over 50. We know that the vaginal health will not improve at all if you're under 50, okay? So you got to have over 50 and usually under about 150.
Okay.
So that is trying to keep it in. Now that's a big range because then we have to go by the bleeding, how much it is, how tolerable it is, how people have any side effects, and what they tolerate. So, if you figure in between 50 and 150 is 100. So if you can get to be in that range, that would be great. If you get up to 140 and the person feels great, that's great. If they're at 70, but they feel great, we have, unfortunately, no published data to say this is the optimal amount. We have the science, we know what happens in a menstrual cycle, And so that's what I'm looking for. And
Okay.
I use blood levels because that's like the gold standard still.
Okay.
For progesterone, we can't even measure the levels that are very useful because they're metabolites, it gets converted to other things. So we go by what the data shows, that if you give micronized, 200 seems to be okay. Sometimes you can go higher if you're having issues. You just have to look for side effects, and you would not usually go lower, but if you have to, because the person says, I feel like I'm drugged in the morning, I like
Yeah.
really too sleepy, then you can go down, but you got to watch the uterine lining because we don't have data showing, that you're going to get optimal benefits. So it has to be individualized, but generally speaking, with progesterone, giving the micronized, we give 200, but you can go higher, you can go lower, but you have to then watch and see the effects. Everyone is going to be individualized. And if it's below 200, you really have to make sure that you're not getting into like an overgrowth situation of the uterine lining, that you're giving enough to get complete shedding, that you're really cleaning it out properly.
And you're not a fan of giving progesterone nightly.
Every single night. Well, that's what people do when they're trying to prevent bleeding.
Okay.
Now, for some women, including some of my patients, they say that's a deal breaker. You know what? I will not bleed every month. It's just not what I'm not accepting it. So here's the problem with that. In order to not bleed, you have to not give enough estrogen to grow the lining. Because if you grow, here's the reality. If you grow it, you must shed it. It's not like you can just like Jack and the Beanstalk and you just keep growing the uterine lining till it, goes into another galaxy. So the uterine lining can't just keep growing. At some point, it's going to start falling out. It's like a tower of blocks, like a little kid
Yeah.
makes a little tower of blocks. Eventually, it's going to fall over. So you
Yeah.
can't just indefinitely grow, or we call proliferate, the uterine lining. If you
Right.
grow it, you have to shed it. So
Right.
you have to give a dose of estrogen that is not going to be enough to have any substantial growth of the uterine lining. But the problem is that if you don't grow the uterine lining, you're not going to grow anything else. It's a package deal as a body. So if you want to have brain-derived neurotrophic factor and improve neuron growth and rejuvenation in your brain, you have to have enough estradiol on board that's also going to grow your uterine lining. If you want to grow and repair bone properly, if you want to grow and repair new skin tissue, if you like go through the whole body, right? If you want to grow and rejuvenate whatever, you have to have enough. It's a dose related event. So if you give such a tiny dose of estradiol to not grow the uterine lining, and then you try to suppress it because the progesterone down regulates the estrogen receptors. So it's kind of like stamping it down. So you give progesterone because that's what happens in a normal menstrual cycle. The first half, when you don't have progesterone, is called the proliferative phase. That's when the uterine lining is growing. The second half after progesterone is called the secretory phase. So it's kind of like a young man who grows and grows and grows, and then he finally stops growing, then he fills out, he gets muscles and he grows. But like, so here you have the kid who's a stick, and then he stops growing, then he fills out. That's like the uterine lining. It grows and grows, and then the progesterone comes on board and it flourishes. It like flowers, and that's what they call secretory. It's like flowers, but it doesn't keep growing.
Yeah.
But if you don't want it to grow at all and not have any bleeding, you have to give a little bit of estrogen, and you have to constantly knock it down with the progesterone. So you will suppress, once again, you can still suppress the night sweats and hot flashes, which is good. But if your goal is not just that, but it's like healthy longevity, because you want to be a super ager, you will be better served by growing brain and bone and skin and maintaining your cardiovascular system better and everything else. I mean, it is a package deal. I can't help it. That's the uterus. This is my thinking. Why can't we on demand have endometrial ablations? An endometrial ablation is where you basically destroy, with either radio frequency or heat, you destroy the uterine lining, but you're not destroying the uterus, just the uterine lining, so that you'll have little to no bleeding afterwards. But that is not the standard of care, but it should be. Why not? If a woman says, I just don't want to have bleeding, or I'll take a spot or two, but I just don't want to have to deal with periods again. I'm like 65. I don't want to have a period. Why
Right.
can't they have an endometrial ablation? Women can walk in to a plastic surgeon's office and on demand say, I want liposuction. I want a facelift. I want my eyelids done. You know, we can go through anything. I want a butt implant. And they all have risk. Every
Right.
plastic surgery has risk. You know, breast implants when you're like 19 years old. There's risk to every cosmetic plastic surgery, aesthetic surgical procedure.
Mhm.
And yet women can walk in the door and say, I want it on demand. Why can't women say, I don't want any more bleeding. I want my uterine lining ablated. I want it like, boop, you know, no longer functioning. That's what should be the standard of care, but it isn't, because I hate it when my patients say, I don't want to bleed anymore, because that means I have to dramatically compromise their health by giving them what is not optimal dosing of their hormones, or the, you know, not having the rhythm, because everything in life is in rhythm, circadian, lunar, seasonal rhythms, intracadian rhythms. Everything is a rhythm.
Right.
That means that in order to accommodate this patient's insistence that she will not bleed anymore, I have to give her what is not an optimal treatment, you know, and I'm not allowed to just say, well, let's ablate your uterine lining, you know?
Right.
So,
Right.
I
Right.
mean, we're not thinking straight. It's okay for women to have a 10-hour facelift, but not to have
Oh,
a
yeah.
15-minute endometrial ablation.
A lot of things don't make sense. That we do in
Yeah.
women's health does not make sense. I know. I want to ask you real quick about these bothersome heart palpitations that so many women complain about. We go to all different cardiologists. We're fine, we're fine, we're fine, but they are real. So
Oh, yeah,
what is
they're
going
real. You
so, I
can
mean,
see
that
them
is
on an
what that
EKG.
that over everything, honestly, is what kind of drove my own self to hormone therapy, because I'm like,
Okay,
I know this is related. I know it is. So maybe just talk about that little depend
sure.
to talk to women so they understand really why this is happening.
Well, there is a neurological system in the body called the autonomic nervous system. The autonomic nervous system controls everything we don't think about, which is most things like our temperature, our pulse, which is, of course, related to palpitations, the constriction or relaxation of our arteries, our digestive tract, motility of the gut, like peristalsis, the digestive enzymes coming out, when the gallbladder contracts, like you name it, everything, when our bladder contracts. So everything in the body that we don't think about, like making tears. I mean, if we had to think about every function in the body, we would never be able to, we'd be alive for like not even 1 minute. So
Right.
all this is under the auspices and control of the autonomic nervous system. You can think of it as automatic nervous system because it sounds so similar. Autonomic. Now, the autonomic nervous system should have a standard state of calmness. So that's called parasympathetic. So that's what you should be most of the time. It means that you'll have good motility function of your gut. Everything with the GI tract will be working. Our arteries will be relaxed and dilated, not constricted. You know, we're going to have a normal, regular, not too fast heartbeat. Okay, not too fast. So we're not going to be like sweating, you know, we're not going to be all clammy. Like everything's going to be like, whoa, really nice, peaceful in the body, working optimally. Well, that's all great. But then when sometimes things happen, like we get chased by an assailant or we get invaded by bacteria, then we go into the sympathetic upregulation. That's the stress state. That should not happen all the time, only when needed. Well, it turns out that the neurotransmitters involved in the autonomic nervous system are modulated, controlled in different ways by estradiol. So the neurotransmitter, because this is a nervous system, nerves work with neurotransmitters. The neurotransmitter that works with the parasympathetic or the calm part is called acetylcholine. By the way, in the brain, that neurotransmitter causes memory to be set, good memory, okay? In the bladder, it's related to bladder contraction. So it's an interesting thing. Remember, I said nothing does one thing in the body.
Mhm.
So in the female, after menopause, she doesn't make enough acetylcholine. That's why she can have word recall problems. I can't remember the name. I can't remember, they usually forget nouns. It's a noun problem. Not too bad on adjectives and verbs, but pretty bad on nouns. And then we have the issue of the autonomic nervous system. So there isn't enough what we call vagal tone. The vagus nerve isn't putting out enough of the acetylcholine. And then the neurotransmitter that's produced by the sympathetic, or we'll call the stress part of the autonomic nervous system, it's epinephrine and norepinephrine. Now, most people have heard of an EpiPen. So an EpiPen would be given if someone has like an anaphylactic response, like that's like the ultimate life-threatening allergy response. And then they get their EpiPen. So the EpiPen causes bronchial dilation. So the things open up in the lungs so that you don't have asphyxia, that you can get oxygen in, because that's part of the stress response, is to open up the airway. So like if you're running for your life from an assailant, you can get oxygen in. But part of the stress response is that your heart will beat faster, right?
Mhm.
And your arteries will constrict. That's so that you don't, and you'll retain fluid. That's so that if you get injured and you start bleeding, that you won't go into hypovolemic shock, that you lose so much blood volume that you go into vascular collapse and you die of shock. So you want to retain fluid, you want to have constricted arteries to keep your blood pressure up. And because you could be running for your life, you want your heart beating faster. And the similar, if you get invaded by a pathogen, your body has to work harder, and similar things come into play. Also, you'll be more prone to blood clotting because your platelets will be activated so that if you get injured, you will clot and then you won't bleed to death. Okay, these are life-saving pathways and mechanisms. But what happens after menopause? You end up with a sympathetic overdrive. You have too much chronic sympathetic output. So you have too much epinephrine, which makes your heart beat fast, right? And norepinephrine, same. So you have too much of that and not enough of the vagal tone that keeps you calm and everything like good with the world, and your heart beats slower. So when a woman goes into menopause and she goes into this sympathetic overdrive and down too little of the parasympathetic, she will very often have the signs and symptoms of too much sympathetic output. Like she'll have trouble sleeping, she'll feel tense and anxious, like more irritable, and she'll have palpitations. She'll have digestive problems because her motility of her gut is now sluggish. She'll have more acid reflux. She'll have like just not feel right. She'll have more trouble sleeping, because she's like always like constant EpiPen injections, like, whoa, and so it's like, so this is what's happening. So what they give, if you go to the cardiologist, they never say, oh, you need what? More estrogen. No, they never say that. They will never say that. They'll say you need a beta blocker. So a beta blocker does actually block the sympathetic nervous system's production of like the neurotransmitter. So it's actually having an effect to block the stress response. That's why occasionally performers who get like performance anxiety, they'll give them a dose of a beta blocker right before a performance so that they will stop feeling like shaky. Because sometimes part of it is like can get tremors, because like, oh, like you're just like, oh, like you're just on like stress mode, you can actually get shaky and palpitations and get even like feel lightheaded. So that's how like performance anxiety, sometimes they treat with a beta blocker. Of course, you can also learn mind-body practices too, because that's actually how mind-body medicine works, meditation, by increasing vagal tone, down-regulating the sympathetic. That's why mind-body medicine isn't woo-woo medicine. It's like real therapy. It really helps regulate your autonomic nervous system. But so does estradiol. By the way, many people are deficient in magnesium, and magnesium has many effects, including working with the autonomic nervous system to help maintain proper heartbeat. So there's a variety of things that you can do. but getting on estradiol is definitely one of them. And so many women have palpitations, and it's not even viewed for what it is, that this is a dysregulation of the autonomic nervous system. So women who are getting palpitations are also more prone to hypertension because it's a package deal. They're going to be more stressed. They're going to have more anxiety. They're going to have more sleep problems. It's not just palpitations. It's going to be the package deal, and they're going to have gut problems. So you giving estradiol and magnesium can often wipe this off the map, and then maybe you don't have to take a beta blocker, because beta blockers also do have side effects. They can make you have weight gain and feel sluggish and cognitive bad, not good. So, I'm not saying no one should ever be on a beta blocker, but that's not root cause medicine.
Right, right. Yeah. Thank you so much for explaining that, because I hear that all the time, and it's always saying that nobody's really addressing it. So I thought we would talk
Yeah.
about that. I just want to finish this conversation with a few questions on PCOS because you're an expert, but I only really want to talk about it in how it pertains to midlife. And I want to start out with the question something like, is it different diagnosing it in midlife? And also, does menopause cure PCOS? That's been asked.
Well, number one, when a woman is like transitioning into menopause, she will often have irregular cycles. So that can be like tricky there.
Mhm.
Androgens come from the adrenal gland and from the ovary. Many women are misdiagnosed with PCOS, and it's really an adrenal overproduction of androgens. And as women age, the adrenal gland portion that's called the zona reticularis that makes the androgens, it literally, like unfortunately other parts of us, it shrivels. So you actually do make fewer androgens from the adrenal gland with aging. So
Mm.
the androgen excess problem can be improved just because you make less coming. Maybe it could be similar from the ovary, but it will be less from the adrenal gland. So that in itself can sometimes improve the androgen excess problem. And then a lot of the symptoms in terms of irregular cycles are going to happen anyway. So the answer is yes. It can be harder to diagnose in midlife. That is true. Most women are nowadays, of course, diagnosed by the time they're 25, but not 100%, so, and if you test some woman and she has very, very high testosterone, though, you got to think of many other things. She could have other problems involving her ovaries or even her adrenal. So remember, everyone should know PCOS is a diagnosis of exclusion. You got to rule out everything else, because she could have a prolactin secreting tumor that's causing irregular cycles and too much DHEAS being produced by the adrenal gland, which is an androgen. She may have a problem with certain cells in the ovaries that make testosterone, and they're like hyperplastic. They're like on fire. They're producing too much. There are rare cases of tumors of the ovaries or the adrenal gland that are making too much androgen. So there's a variety of things. You have to rule out everything else that can cause androgen excess, and look at thyroid, because of course thyroid can give you irregular cycles. So you got to look at everything. It's a diagnosis of exclusion. So nobody should be diagnosed purely based on just symptoms. You need to have a workup. In terms of menopause curing it, for the longest time, this was said by so-called experts. I say that because it's like, I just don't know where their minds are sometimes. But they were saying for the longest time that after menopause, there's no difference in women in terms of anything, if they did or didn't have PCOS, kind of essentially implying that menopause cures PCOS. We now know that's ridiculous, because the same underlying metabolic problems are already put in play. So the thing about it is that women are not going to have the same issues after their ovaries are now, out of function. They're not going to be working anymore. But all the problems that were metabolically set in motion are still in motion. So women who've had PCOS have dramatically higher rates of hypertension, diabetes at much earlier ages than women without PCOS. We're talking like classic PCOS. So those women, you might say, had a head start on cardiometabolic conditions or disorders. So they have a running start on having problems with their heart, their arteries, their glucose regulation. So, and they're not going to suddenly like make everything better. So it's actually now published and accepted that women who go into menopause with a history of PCOS have a higher rate of bad things happening to them at a faster clip than women who didn't have that. We now know, well, I knew this decades ago, but now it's accepted in mainstream that pregnancy is a indicator of risk for women when they go into menopause. So if a woman had pregnancy-related complications like gestational diabetes, hypertension, preeclampsia, preterm labor, early delivery, macrosomic, like giant babies, abruptions, all these different, basically any and every medical complication of pregnancy, when they transition into menopause, that group has a dramatically higher risk of having earlier onset of things like heart attacks and strokes and diabetes than other women. And what group has the most risk for those complications in pregnancy? It's women with PCOS. So yes, women with PCOS are at higher risk of all the bad stuff once they get into menopause. They should be like very proactively treated in every which way with hormones, with lifestyle, and if necessary, pharmaceuticals, because they are a very high risk group. And it's often not recognized. That's why every doctor should be taking a health history involving pregnancy history of every woman at all times, and especially from age 40 up. This is like really predictive of risk, and it's often missed.
Yeah. Are you a fan of the traditional metformin and spironolactone or supplement line, or just diet, diet and lifestyle mainly? You mentioned pharmaceuticals, but yeah.
Well, I actually like spironolactone in a weird way. It's a blocker for aldosterone. Aldosterone is an adrenal hormone that is activated by the stress response. And I talked a lot about the sympathetic, parasympathetic. Women with
Yeah.
PCOS have an overriding activation of their sympathetic. They have too
Okay.
much sympathetic output versus parasympathetic. So they're always in that sort of stress state, and they will produce too much aldosterone. And so spironolactone is a blocker. So it actually has some benefits, and it's as long as you don't get pregnant on it, because it blocks, it changes and lowers testosterone. So that if you have a male baby, you're going to make him kind of weird because his testosterone is not going to be right. So you cannot get pregnant on spironolactone. I mean, you could, but that's very bad. Okay,
That would
it's
be
a
bad.
teratogen. But other than
Okay.
that, spironolactone has, like every drug, it has some side effects, but it's actually can really help lower testosterone, receptor for testosterone, the conversion, because it's sort of lowering inflammation. It lowers aldosterone, fluid retention. It can do some good. It can lower the conversion of testosterone to its more powerful counterpart, dihydrotestosterone. So many women will do quite well with, if they have high testosterone, to go on spironolactone. I am not a big fan of metformin. So
Okay.
metformin, whenever they've done studies comparing exercise and metformin, guess what? Exercise always wins. So yes, I would rather go with lifestyle. And this is not the same, but I liked other things like cinnamon and berberine, and there's other natural things that, and then fasting, time restricted eating. We can almost always, and I give my PCOS women estradiol. I give them bioidentical hormones because one of the things that is not well recognized for whatever reason is that women with PCOS have a lot in common with women that are transitioning into menopause. They don't, it's a different process, but the outcome is that they don't have enough estradiol in their bodies and their estrogen receptors are not working properly. So basically they live in a body that's estradiol insufficient, and estradiol manages all these cardiometabolic functions. So giving them bioidentical hormones, and they're not ovulating, so they're not making progesterone. So giving them bioidentical hormones for like maybe a year while you work on all these lifestyle things, I think of them as training wheels. You give them the bioidentical hormones, you do all the lifestyle stuff, you give them all the supplements, sometimes pharmaceuticals if you have to, and then you take it away. and guess what? Often then they'll have regular cycles. They've lost weight, their gut, you're working on the estradiol is very critical for the gut microbiome. When you don't have the right estradiol, your gut microbiome immediately becomes abnormal, dysbiotic, you get leaky gut. That's been now proven in women with PCOS. They virtually all have leaky gut. So you give them the hormones that they're not making, and then you work on all their health, and then you take away the hormones. And then in many cases, not 100%, they will continue to make their own natural hormones. So it's sort of one of those catch-22s. You can't heal without the hormones, and until you heal, you won't make the hormones. So we can actually do a lot, but it's not standard of care, but it's not illegal. So it's good. It's a lot safer than birth control pills. I'm giving bioidentical hormones, not birth control pills. Now, in terms of preventing, yeah, it does. I know, like, duh, it does. In terms of birth control, so birth control is an ongoing problem because fertility is a vital sign of health, and fertility is essential to being a healthy female in the reproductive years. And of course, loss of fertility is associated with loss of optimal health. So I prefer, now I have to do what I have to do. I can't have women have unwanted babies. I have to do it. But my wish is that women will use, if necessary, 2 barrier methods at the same time, which gives you the same efficacy as anything else without actually getting rid of their functioning of their ovaries, which to me is essential for optimal health. So you can use condoms, which, by the way, single, younger, and older women should all be using anyway. So you use condoms religiously, and they have really good ones that don't affect sensation or anything. Some people even think they're enhancers. So you use a condom, and then you can use either an old-fashioned diaphragm, which actually works, and I fit them, or you can use Phexxi, which will change the pH of the vaginal environment to make it hostile for sperm. And if you use use condoms and something else, it's absolutely effective. And I say, young women, like, if you can't do this, then you're not ready for having sex. You're just not, because to put you on, now we know this is like, unfortunately, a fact. You build most of your bone in your second half of your teen years, and then just a little bit into the 20s. And those are the years they're putting women on, their kids, on birth control pills. You will never optimize your bone health. You're not going to optimize your cardiovascular health. There's an article published showing teens who start on birth control pills have a higher rate of heart attacks and strokes when they get older. So, I don't want unwanted pregnancies ever, ever. I want that to be not a problem. But I also feel that it's really critical that the word get out that there are consequences to going on hormonal contraception in the teen years and going into the early 20s, even more so than later. Like, we keep making brain until we're like 26, and these are interfering. They're endocrine disruptors. They're designed specifically as endocrine disruptors so that you don't function normally, so that your ovaries don't work. I mean, these are not replacing hormones with anything other than poisons. Now, they're slow poisons, granted, but they're toxic chemicals. If you go to toxicology.gov, they're listed as endocrine disruptors. So we would never give our little girls, like plastic ground up into like little capsules. But so I don't want to say that I would never prescribe birth control pills, because I have to. I have to look at relative pros and cons at every age. But I wish that it could get out that, birth control pills definitely work, but so do other things, if you can have like a responsible person. But usually once somebody gets into their 20s, they can be much more responsible. And then if you're a teen and you want to be sexually active, maybe you need to really be sat down and told, like, number one, you always have to use condoms anyway. So maybe you could do something else with it, and it will be very effective. I mean, but I have to do what I have to do to prevent unwanted pregnancies. It's just what it is. So, if I have to, I'll give contraceptives that have hormones. The copper IUD has its own set of problems, but it doesn't change your hormones. So if I had to choose something that is long acting and hands off, you don't have to do anything around the time of having sexual relations, I would pick a copper IUD. I don't
Okay.
love it, but I hate it less. But
Yeah.
once again, what I hate the most is an unwanted pregnancy. So I
Well,
have to,
exactly. That
I-
exactly. Yeah.
what I have to do, I have to pick. And
Exactly.
the same, and women who have PCOS, they can't assume that they're not going to get pregnant because they have irregular
Right.
cycles. They
Right.
could just hit it just right and get
Right.
pregnant. So you
Right.
got to use contraception. You have to, or
Right.
just, or don't have sex. But I know that's probably, pie in the sky, but, I wish that people understood. I mean, all you have to do is deal with a crying teen who has a sexually transmitted infection, to just, that's why I think sex ed is so important. Everyone should have informed consent. Everyone should know the risks before
Right.
they engage, I mean, so,
Right.
I'm not, everyone's going to have sex, but do you, you want to do it responsibly. And
Exactly.
when you're mentally and emotionally ready for it and
Right.
so on, you don't want to be bullied into something. So these
Right.
are like
Right.
big separate issues here.
No doubt.
But
No doubt.
PCOS definitely is a risk factor for every cardiometabolic issue, high risk for pregnancy complications, much higher risk when those women enter into the menopausal years for all the bad stuff that can happen, and are treatable,
Yeah.
and even sometimes curable. But I'll just say we can put them into long-term remission.
Yeah. Okay. I got you. And it's interesting with birth control that that's pretty the standard care for perimenopause.
Well, it is, and it's simple. I have to say it's simple,
Yeah.
but I've never looked for the easy way out, I guess.
No, no. Well, is there anything that I didn't ask you that I think that you feel was important for women to know?
I
Anything?
think it's important for every woman to just take charge of her own health. And if she goes to a healthcare practitioner who tries to scare her out of going on bioidentical hormones, she needs to move on. It's that simple, because once again, this is a bottom up kind of a movement here. I'm the top down, but I'm a minority. I'm totally open about that. I am not in the majority of doctors and OB-GYNs being an advocate for hormones, but it seems like so ridiculous because it's really not complicated thinking. It's complicated what hormones do on a cellular level, but understanding that hormones are really important to do a lot of important things is not very complex. And, it's a hormone insufficiency and then deficiency. And we treat every other hormone deficiency and insufficiency with hormones. And then I'm just saying, treat it the same and
Right.
take charge. Don't settle. This is your life.
Right. Right. Thank you so much. You are a wealth of information, and it's just been awesome having you on. Just tell everybody where to find you.
Well, I'm actually right now sitting in an office exam room that I converted into my video room. And so I'm an old-fashioned doctor. I still have a physical office, brick and mortar, that people come in every day of the week, usually not Saturdays, but Monday through Fridays. And I see patients all the time. I can do some telemedicine as well. And so my practice is called Integrative Medical Group of Irvine. And Irvine is in Southern California in the OC. And I also have my books, like you mentioned, and I have an Instagram Live where I try to put out information every week, and I post a lot of educational information on my YouTube channel. So I'd love for people to follow me and watch these things so that you can have information, so that you have the tools to make your own decisions for your life and your health. So I'm here. I hope to write more books and be
Yeah.
on more podcasts and such. So,
Yeah.
you can Google me and you'll find a lot of other stuff out there.
Yeah.
Hopefully good stuff.
Exactly. No, it's good. It's good. Thank you so much. I really appreciate your time. And I know everybody else, you have provided invaluable information is all I can say. So thank you so much.